Hello everyone, I'm Daniel Steele and I'm coming to you from the traditional, ancestral, and unceded territory of the Musqueam people. In this lecture, I'm going to talk to you about ethics and the opioid crisis. This lecture will cover the reader article from week 11. So let's begin with some background statistics to give a sense of the scale of the problem in Canada. So if we look at the period from January 2016 to September 2024, we can see about 51,000 people died from opioid toxicity deaths. Obviously, that's a very, very large number. And if we zoom in on just the previous year, 2024, from the period January to September, there's about 5,600 people who died from opioid toxicity, or about 21 opioid-related deaths per day. And that is a slight decline from the previous year in 2023 of about 12%. However, it's still a very high level. So by comparison, it's about twice the number of deaths per day compared to what was happening prior to the COVID-19 pandemic. Moreover, the bulk of these deaths are due to fentanyl and other synthetic opioids and not to sort of prescribed pharmaceutical opioids. One of the things that Reader emphasizes is sort of the prehistory of the opioid crisis, about what sparked this. And this is related to some of the claims he makes about the ethics. And so it's important to understand that the opioid crisis is predominantly a United States and then Canadian problem, not a global problem mainly. That's not to say people don't use opioids in other countries, which of course they do, but that this sort of crisis that's occurring in Canada and in the US is mainly in these countries and not globally distributed. So the origin of this opioid crisis in Canada and the United States is the approval by the US FDA of a drug called OxyContin that was made by a pharmaceutical company named Purdue Pharma. This was a slow release formulation of oxycodone, and in the materials that were approved by the US FDA that often influence physician prescribing, those materials stated that OxyContin was safe for many uses, for ordinary kinds of pains like back pains, dental work pain, all kinds of pains like this, that it could be prescribed for all kinds of uses without risk of addiction or abuse. In 1996, Health Canada basically followed US FDA's approval on OxyContin and approved it with very similar language about how safe it was and how it was not a risk for misuse or addiction. By the late 1990s, there were many media reports in the USA about OxyContin misuse, about deaths, about whole towns being, being sort of taken over almost by this problem in places like West Virginia and so on, and this led to a black box warning being placed on OxyContin in the United States by the FDA. However, in that same year, Health Canada published an article in the Canadian Medical Association Journal stating that these problems were limited to the US and they did not see any evidence of these problems in Canada. That again proved to be sort of terribly mistaken, and within a few years there were similar media reports in Canada of OxyContin misuse and deaths and so on. So this is sort of the origin of the crisis, but as Reader emphasizes, the opioid crisis has evolved quite a bit over the decades. And so although it began as a prescription opioid problem, it is now predominantly not a prescription opioid problem, as some of the statistics we were looking at on the first slide suggested. So this graphic from the U.S. Centers for Disease Control describes sort of these three waves in the opioid crisis prior to the COVID-19 pandemic. So the first wave was the prescription opioid crisis, and that's starting in the late 1990s, and that's this light blue line right here. And you can see by the the early 2000s, this is the predominant opioid crisis was from the prescription opioids. However, in about 2010, you can see the numbers from heroin begin to rise, number of deaths from heroin begin to rise, and then 2013, synthetic opioids start to rise really sharply, and soon just completely overtake everything else. And so that by the time you're in 2019, the opioid crisis which had began as a prescription opioid crisis, had morphed into something extremely different. It had morphed into a synthetic opioid crisis. Okay. And Now, if we go to COVID-19, what we see is that COVID-19 took this synthetic opioid crisis, which was already a very serious problem, and made it almost twice as bad as it was before. So you can see here, this is 2019 turning into 2000. You can see these numbers just really go up very dramatically. You see the slope on this curve really just takes a real turn upwards. And you can see similar effects in data from Canada. So here we've got opioid toxicity deaths from January 2016 to June 2025. And so you can see this is the pre-pandemic period here. And then you can see the pandemic kicks in. And again, you can see this very sharp slope in the rise of opioid toxicity deaths. And so you can see here when we're in the pandemic, it's about twice what it was in the pre-pandemic. However, on the more slightly optimistic side, if we look at 2024, we can begin to see these numbers starting to come down. This is a pattern that's also been seen in the United States. Hopefully this trend will continue, but you can see these are different scenarios that are being laid out here with these different colored lines. Obviously at this point, we don't know how this will go, but hopefully the trend will continue to move in a positive direction. So if we're connecting this back then to the Reader article, one of the things that's interesting is that Reader himself has a personal interest in this topic due to himself having developed an opioid dependency as a result of a serious motorcycle accident that he was involved in that resulted in multiple surgeries and him being on opioids for an extended period of time, and then very aggressively and rapidly tapered off those opioids by his physician. And then, as a result of that rapid and aggressive tapering off of the opioids, going through some major severe withdrawal symptoms. And if you're interested in hearing the story, you can click on this link to a TED Talk where Reader describes his experiences. And after he had recovered from his opioid dependency, Reader really became interested in the ethics of this topic, and he went around giving lectures about his experience and some of his views about the ethics. And after one of these lectures, he received an email from someone who said, "Well, here's the CDC Pocket Opioid Tapering Guide," and which gave recommendations about how to taper someone off of opioids. And one of the things that it suggested is that you should be very gradual about this tapering and not nearly as abrupt as he had been tapered off of this. And it struck him that there was something really ethically wrong with this, that apparently so many doctors did not seem to be aware, at least in the US back then, about how to appropriately taper people off of opioids, even though they were prescribing these opioids in quite large quantities. So here are just some questions we can think about. We might discuss these in the class: how Reader's experience relates to the waves of the opioid crisis, and how might his outcome have been different if he were less advantaged. Reader was a bioethicist and with a nice job and a nice family. From his own story, it's quite clear that was very important to his ability to be able to move through his difficulties and recover. But for today, in this lecture, what I want to focus on is a conceptual puzzle that Reader talks about. When he began going around and speaking about these issues, he encountered people who would say, "Well, this isn't really an ethics problem. We know the solution. We know how to solve this problem, and it's just a matter of having sort of the political will to do it." But what he found is that people would say that, and then depending on who they were, they would advance very different solutions. So if he was talking to, say, physicians, medical doctors in a hospital, they would say, "Oh, it's a prescribing problem. We just need to limit the supply of prescription opioids. We need to get the prescribing under control, and that will solve the problem." If he was talking to public health folks, on the other hand, they would say, "Oh, this is a social determinants of health problem. This is people use drugs because of poverty or because of other social reasons. And we need more treatment. We need more harm reduction, including access to safe supply." And so Reader was struck by the fact that, number one, these people were very confident that they knew the solution, and yet these solutions were different, and at some levels even apparently sort of in conflict with one another. So, for instance, if you think access to safe supply is a big plank of the solution, it's not clear how that's going to be compatible with limiting the supply of prescription opioids. And so this led Reader to think about, what are the ethics, what are the mindsets behind different views that people have about about opioids. And in the reading, he describes two different sort of mindsets that people often have, sort of out there in the world, whether they're sort of ordinary folks who you might meet or whether they're, academics. And so on the one side, there's this backward-looking perspective that drugs are bad. People who use drugs should be held responsible for their behavior, and that the solution is to really focus on restricting supply and treatment, but treatment in the form of abstinence. On the forward-looking side, on the other hand, and this would probably be more folks in the public health realm, the idea is that it's not the drugs themselves that are bad, but it's the harms of the substance use disorders that are bad. And that people who suffer from substance use disorders are people who need help and they're in need of treatment, and we shouldn't be blaming them in any way for their problems or difficulties. And moreover, instead of restricting supply, the focus would be on harm reduction and treatment, and that treatment would be understood to involve maintenance, that is, treatments that would prescribe opioids that are less dangerous than unregulated opioids that someone might buy on the street. So those could be things like methadone. They could also be hydromorphone as part of a safe supply program. Now, Reeder's overall sympathies, I think, are more with the forward-looking approach in many ways. At the same time, he doesn't completely adopt the forward-looking approach, and I think that's helpful and that's important to see. So his own view, he describes in terms of the value neutrality of drugs. Now, that is kind of consistent with the forward-looking approach, but as we'll see, it differs in some ways. So the key idea is that drugs are value neutral. And here's a quote. He says, opioids basically, like all pharmacotherapies, have risks and benefits. They are neither inherently bad nor inherently good. They are tools that must be used judiciously. And so obviously this differs from the backwards looking view, and drugs aren't inherently bad. At the same time, though, he differs from the forward-looking view by emphasizing that oversupply of drugs can be a public health problem. And here's a quotation where Reeder discusses this. He says, "The fact is that gluts in the supply chain of dangerous drugs have, historically, tended to produce overdose epidemics. One of the reasons people take drugs, it turns out, is availability. Having the streets awash in heroin or oxycodone is not good for public health, and so addressing supply is one of the ways of addressing demand." So when he mentions historically, the sort of the gluts of supply of drugs have tended to produce overdose epidemics. One example of the history is, of course, the OxyContin one that we discussed earlier, but there are other examples as well. So in the early 20th century, many of the opioids that we know today, and some of which are regarded as having no medical use, such as heroin, were actually things that you could buy sort of over the counter, and that there were pharmacies that would sell these sort of patent medicines like laudanum that were these sort of cough syrups or sort of these cure-all kinds of things that actually contained things like morphine or opium in them. And this created a whole sort of period of people becoming addicted to these kinds of sort of over-the-counter medications, and that resulted in a sort of stricter rules in many countries, including the United States and Canada and Great Britain, stricter rules about opioids. And so that's another one of these historical examples where this sort of easy demand of opioids led to overdose epidemics. So one of the things that this view would suggest is that legalization, for example, an arrangement where you could just have like state-run opioid stores where you could just go and buy opioids, that this would be a bad idea according to this view. What this implies about something like safer supply is a little less clear. In some of his writings, not this publication, but other writings, Reeder has expressed support for safer supply if they're done with proper safeguards. But we'll see that this issue and this concern that increasing the supply can increase the number of people who develop opioid use disorders is definitely one of the main concerns that comes up in regards to safer supply programs. That we'll discuss that in the second lecture, and of course that's one of the topics in the second reading as well. Okay, so that's it for now, and I'll see you again soon. Bye-bye.